Hi everyone. Today we are going to start our discussion on depression. There's a lot of information in this PowerPoint on depression, and we're going to talk a lot about it in class this upcoming week. So anything you don't understand, just jot down. Any questions that you have, just jot down, and we'll definitely talk about them. So a lot of times you'll get clients that come into your office that present with overall feelings of sadness or emptiness. Sometimes they can describe it as an empty feeling. So it's really important to understand the DSM-5 criteria for major depressive disorder when diagnosing. And the symptoms are displayed right on your screen. So the criteria calls for 5 or more of these symptoms in the same 2-week period. So the duration is really important. And that symptoms must include number 1 and number 2. So number 1 is a depressed mood, so just an overall feeling of sadness. And number 2 is anhedonia. And anhedonia is defined as the lack of pleasure or capacity to experience it in things that you used to find pleasurable. So that would be like if a client comes in and says, I used to like to go to the movies with my husband all the time, and now it's just not fun to me anymore. And I used to enjoy, doing yoga and going for bike rides, and now it's not fun anymore. So it's something that you used to have pleasure doing, but you no longer have pleasure in doing that anymore just because you feel sad. The other criteria is significant weight loss or gain, not due to dieting, insomnia or hypersomnia. So insomnia would be I can't sleep at all, and hypersomnia would be I want to sleep all of the time. So major depressive disorder is one of those disorders when a client presents with the criteria for that you want to ask about their sleep patterns. What time do you go to bed at night? What time do you get up in the morning? Do you sleep all night? And we'll talk about that this week. Psychomotor agitation or retardation. So are they fidgety? Are they moving all over the place? Or are their movements very slow, very calculated? And is this a change from the way that they used to move? Fatigue or loss of energy. Also, loss of motivation kind of plays into that loss of energy piece. Feelings of worthlessness or excessive and inappropriate guilt. That's a big one. So feeling like, nobody cares about me, there's no reason for me to be here, or feeling like little things that happen, you have this extreme amount of guilt over them happening. That's kind of not rational thinking. Diminished ability to think or concentrate or indecisiveness. Again, this is a change. So all of a sudden I can't think, I just can't concentrate because I feel so empty or I feel so sad all the time. And then recurrent thoughts of death or suicidal ideation or attempt. Very important anytime a client presents with sadness to talk about suicide. Have you ever thought about harming yourself? Have you ever thought about harming others? If you are going to harm yourself, do you have a plan? And this week we'll go over a little bit of safety planning and how to kind of talk about suicidal ideation. And then there's a note in the DSM that the impairment and distress is not better explained by a substance use or by a medical condition or by, so substance can be kind of illegal drugs or alcohol, but they could also be prescription drugs too, or by schizophrenia, spectrum, or psychotic disorder. And then no history of mania or hypomania. So we're going to talk more about mania and hypomania when we look at bipolar, but mania is defined as this just intense, wonderful, awesome, I'm on top of the world feeling, and it looks like you're totally out of control. So it's just this intense feeling of being, it's almost like feeling high. So if that's present, then we're probably not looking at a major depressive disorder. So we will talk more about that this week. So these are the major depressive disorder specifiers found in the DSM. If you look on page 184, they give a really good description of what each one means. I'm going to go over them quickly with you. Mild would be 2 symptoms. And remember that symptom 1, depressed mood, and symptom 2, anhedonia, have to be there. So this is 2 symptoms in addition to this depressed mood or anhedonia. Moderate would be 3 symptoms. Severe would be 4 or 5 symptoms. With anxious distress, this means the presence of at least 2 of these. So feeling keyed up or tense, feeling unusually restless, difficulty concentrating because of worry, fear that something awful might happen, this catastrophic thinking, or feeling you might lose control of yourself. So when you have a client that presents with what you think looks like a major depressive disorder, and they also have this anxiety, this anxious distress, you could either specify it, and their primary diagnosis would be MDD with anxious distress, but you could also rule out anxiety as being the primary diagnosis. And we'll talk about that next week. Let's see, with mixed features, that would mean at least 3 are present nearly every day during the majority of days of a major depressive episode. So 3 of these have to be present nearly every day during the majority of days in that 2-week period. Elevated mood, inflated self-esteem, more talkative and pressure to keep talking, racing thoughts, increase in energy, increased involvement in activities that have a high potential for painful consequences, like a shopaholic spree or sexual discretions, a decreased need for sleep. And all these symptoms must be observable by others and represent a change from normal behavior. So, and these symptoms are important to look at because they can also meet the full criteria of mania, which we will talk about in a couple weeks. And if these symptoms meet this full criteria of mania, then the major depressive disorder would not be the correct diagnosis. Bipolar 1 or bipolar 2 will be. But we'll talk about that. With melancholic features, one of these has to be present. So loss of pleasure in all or almost all activities, lack of reactivity to usually pleasurable stimuli. So that means even when something good happens, I don't feel better. And then 3 or more, profound despair or empty mood. So clients will present all the time with just this overall emptiness. I feel nothing, which is depression. So I think a lot of people think that depression is just sadness, but it can also be emptiness. Worse depression in the morning, early morning awakening. So I wake up really early and I just feel very sad and really very empty. Psychomotor agitation or retardation, again, fidgety or marked slowness. Anorexia or weight loss, and excessive guilt. And then with atypical features, so features happen during the majority of days. Mood reactivity, so something good happened and now I feel a little bit better. And then you need 2 or more, so significant weight gain or increase in appetite. Hypersomnia, leaden paralysis, so that means like this really heavy feeling in your arms or this really heavy feeling in your legs. Patterns of interpersonal rejection, sensitivity that results in significant impairment in social or occupational functioning. So my friends hate me, so I'm not going to go to school. Or I can't get along with my coworkers because I just feel so sad and empty all the time. I just don't care, and now I can't go to work. With psychotic features, so delusions or hallucinations are present. And we're going to talk a lot about delusions and hallucinations, but that would be the specifier if those are present. Let's see. Mood congruent means that delusions and hallucinations are consistent with typical depressive themes such as personal inadequacy, guilt, disease, death, or deserved punishment. And then mood incongruent would mean that the delusions and hallucinations are inconsistent with typical depressive themes. So I'm not thinking about how inadequate I am as a person. I am thinking I'm hallucinating about something else. With peripartum onset, so symptoms occur during pregnancy or in the 4 weeks following delivery. With seasonal pattern, that's SAD, seasonal affective disorder. I see that a lot because we live in upstate New York where there's no sun 6 months of the year. So lots of clients that will present with their symptoms that worsen maybe right after Christmas and last till April. In partial remission means that symptoms are present, but the full criteria are not met, or there is a period lasting less than 2 months without any significant symptoms of a major depressive episode. And then in full remission, that means during the past 2 weeks, there has been no symptoms of major depressive disorder present. So if your client comes in, presents with major depressive disorder, you put a treatment in place, you move along your treatment plan, you get to the point in your treatment plan where the client has not felt they feel better, they don't have any of the criteria symptoms, then you would write on your treatment, on your progress note, which we're going to do this week, in full remission. So I went through those really quickly. Questions about those, jot them down, and then we'll talk about them in class. So persistent depressive disorder, this used to be called dysthymia. Let's see. The prevalence rate of persistent depressive disorder is 0.5% to 1.5% of the population is said to have symptoms of persistent depressive disorder. The DSM-5 combined dysthymia and chronic major depressive disorder into a single category, and that's where they came up with dysthymia. So dysthymia, or with persistent depressive disorder, sorry. So this is mild depression that is persistent and chronic. It must last at least for 2 years in adults and 1 year in children. It has an early and insidious onset. It's a chronic course. So it's basically you feel depressed most of the time, all of the time. The term double depression was coined. That's when you might have dysthymia plus a major depressive disorder. So you just have this underwhelming or undercurrent of I feel sad all the time. I have this depression all the time. And then it spikes and you have a major depressive episode. So about 25% of people with major depressive disorders have dysthymia. Oh, although it may no longer be true with DSM-5 changes. We'll talk about that. We'll talk about that in class. Familial aggregation. So dysthymia runs specifically in families. So it's heritable, along with chronic major depressive disorder, which also supported the change in the DSM. And this may also represent a more severe subtype of major depressive disorders. Risk factors for persistent depressive disorders include higher levels of neuroticism, which is negative affect, greater symptom severity, poor global functioning, and presence of an anxiety disorder or conduct disorder as a child. Childhood risk factors include a parental loss or separation. And a number of brain regions have been implicated in persistent depressive disorders, including the prefrontal cortex, amygdala, and hippocampus. So, there's a lot of research out there that it is biological. And then persistent depressive disorder is also related to poor self-esteem, greater cognitive biases, poor treatment outcomes, and greater comorbidity with other disorders. So major depressive disorder and bereavement. The DSM-4 had bereavement in there as a mental illness, and the task force for the DSM-5 removed the criterion for bereavement from major depressive disorder, and it essentially relies on our clinical judgment to distinguish a depressive episode from normal bereavement. The change was based on previous evidence that bereavement-related depressive episodes are hard to distinguish from non-bereavement-related episodes. So this is one of those times where I want you to write this down. Why do you think, or what are your thoughts about the exclusion of the bereavement criterion from major depressive disorder as a symptom? So write that down. What do you think about that? And we'll talk about that in class a little bit more. Disruptive mood dysregulation disorder. Let's see. DSM-5 criteria. So severe recurrent temper outbursts manifested verbally and or behaviorally that are grossly out of proportion in intensity or duration to the situation or provocation. So like it's a temper tantrum, you are flipping out, you're out of control, and it has nothing to do with the situation. It's totally out of proportion with it. They're inconsistent with developmental level. So if you go down a little ways, the diagnosis should not be made for the first time before age 6. Or after age 18. So a 2-year-old who is throwing a temper tantrum in Wegmans on the floor because their candy dropped on the floor and they can't eat it, that would not be considered something that would be grossly out of proportion of intensity or duration to the situation. But a 10-year-old who throws himself on the floor in Wegmans because they can't eat a piece of candy, that would be considered grossly out of proportion intensity to the situation, especially if it's going on and on and on. So the temper outbursts occur on average 3 or more times per week. And then the mood between each temper outburst, the kid's irritable, angry most of the day, nearly every single day. So this is a very, very unhappy person, a very irritated kind of person, and then boom, these temper tantrums come up. And it's observable by others. So this is something that, the teachers are going to see, parents are going to see, friends are going to see. So there's a lot of implications to being diagnosed with disruptive mood dysregulation disorder in terms of how it affects you socially, how it affects you academically. So it says criteria A through D, so those are the first listed there, have been present for 12 or more months. Throughout that time, the individual has not had a period lasting 3 or more consecutive months without all of the symptoms. So for a year, imagine a client that presents with this and the parents that are dealing with this for a year. So this is a very difficult diagnosis. And then criteria A and D, so severe recurrent temper outbursts, and then the mood between temper outbursts is irritable, happens in at least 3 settings. So, and in 3 settings is interesting. So it has to happen across settings. So this is happening at home, this is happening at school, this is happening with your peers, and are severe in at least one of those settings. The diagnosis, like we said, the age range is very important. By history or observations, the age of onset of criteria A through E is before 10 years old. So really, the magic age for diagnosing this is between 6 and 10 years of age. There's never been a distinct period lasting more than 1 day during which the full symptom criteria, except duration, for a manic or hypomanic episode has been met. So that just means that this client is irritable and throwing temper tantrums all of the time. Like there's not a time where they have this intense feeling of pleasure or happiness. The criteria for that has not been met. The behaviors do not occur exclusively with an episode of major depression disorder and are not better explained by another mental disorder. And they're not attributable to the physiological effects of a substance or another medical or neurological condition. So the prevalence range for disruptive mood dysregulation disorder is from 2% to 5% of the population. It is more common in males and school-age children than in females and adolescents. In adolescents, it looks more like bipolar than disruptive mood dysregulation disorder. Let's see. Risk factors include temperament. So we're going to talk a little bit about temperament this week. So when from the age of that you're born to the age of 18, you have what's described as a temperament. And then once you turn 18 into adulthood, it turns into your personality. So we're going to talk about that specifically around personality disorders. Environmental, risk factors include temperament, chronic irritability, and then some children have also met the criteria for ADHD, right? Because outbursting, you're all over the place, you're persistently irritable, could look like ADHD, and or anxiety disorders, again, could look like anxiety. I don't want to do this, I'm going to freak out, or I'm irritable all the time, which looks like anxiety all the time in kids, and have qualified for a diagnosis of ODD. And we're going to talk about ODD as well. Premenstrual dysphoric disorder. Let's see. I'm looking at my notes. Premenstrual dysphoric disorder. The prevalence rate for this is 1.8% to 5.8% of menstruating women. Onset can occur at any age after your first period. Many individuals report that symptoms worsen as they reach menopause. So the criterion for that, in the majority of menstrual cycles, at least 5 symptoms must be present in the final week before you get your period, start to improve within a few days after you get your period, and become minimal and absent in the week that you don't have your period. So these women get one week a month of feeling kind of okay. So one or more of the following symptoms must be present: marked affective lability, so mood swings, feeling suddenly sad or tearful for no reason, increased sensitivity to rejection, marked irritability to anger, or increased interpersonal conflict. So this is beyond the norm. Like all of a sudden I feel anger all the time, I can't get along with you all the time. Marked depressed mood, feelings of hopelessness or self-deprecating thoughts. So I'm sad, I feel empty, I hate myself. Marked anxiety, tension, and or feelings of being keyed up on edge. So like just feeling like something's going to happen all of the time. So you need one or more of those. And then you need one or more of these other following symptoms to reach a total of 5 symptoms when combined with symptoms from criteria B or above. So it's tricky because you need one or more, but together you need 5. So decreased interest in usual activities, looks like anhedonia again. Subjective difficulty in concentration, lethargy, easily fatigued, marked lack of energy, marked change in appetite, overeating, specific food cravings, hypersomnia, I don't want to sleep, insomnia, I want to sleep all the time, or I mix that up, hypersomnia, I want to sleep all the time, insomnia, I don't want to sleep, a sense of being overwhelmed or out of control, and then physical symptoms such as breast tenderness or swelling, joint or muscle pain, a sensation of bloating or weight gain. And these are symptoms that all women feel as their period is coming on. So it's really important, or most women, I would think, to look at the duration. So that they have to be present, that week before you get your period, they start to improve, and then they become absent for 1 week. The symptoms are associated with clinically significant distress or interference from work, school, usual social activities, and relationships with others. So I don't want to go to school, I don't want to go to work, I don't want to be around people. It's not merely an exacerbation of the symptoms of another disorder. So you have to rule out other disorders first. Criterion A should be confirmed by prospective daily ratings during at least 2 symptomatic cycles. So at least 2 months of daily ratings of how the client feels before you can give this diagnosis. That's important. And the symptoms are not attributable to the physiological effects of a substance. Environmental factors for PMDD include stress, history of interpersonal trauma, seasonal changes, and then female gender roles. And then heritability is unknown, but estimates range from 30 to 80%, which really speaks to it being unknown because that's a huge range. So the epidemiology of depression, the 12-month prevalence rate is 7 to 10%, and the lifetime prevalence rate is 16 to 17%, which is a little bit higher. Somewhat lower rates in minorities in the U.S. So this is another thing that I want you to take a second and jot down. Why do you think that the data that is reported, this comes from the CDC studies, but why do you think that it shows that there are lower rates in minorities in the U.S.? Jot down a few assumptions or hypotheses that you have about that. The ratio, 2 to 1 female to male. So there's some explanations for that the research shows. Hormonal variation, rumination, so thinking about things over and over and over again. Females tend to do that. Interpersonal stress, exposure, and sensitivity around female relationships. Socialization of females, social roles of females, and then anxiety, gender differences. So anxiety and depression are closely related. So a lot of times when somebody has a diagnosis of depression, they might also have a diagnosis of anxiety. So that accounts for why more females might have depression. The average age of onset is in your mid-20s, but remember it can occur anytime during the lifespan. And then there's a high surge in prevalence during adolescence, specifically among girls, which I thought was interesting. It makes sense, but it's also interesting that the data kind of shows that. The average duration of a major depressive episode is about 5 months. The longer that you have it, the less likely you are to recover from it. The risk of chronicity is 15 to 20%. And then predictors of a longer episode, so the duration of the episode up to that point. So how long was my last episode of major depressive disorder will predict what this one will look like. If you have a personality disorder, or if there's another comorbid axis 1 disorder. So that means something else is going on. You've been diagnosed with another disorder as well. And then 1/2 to 2/3 of people have reoccurrences of a major depressive disorder, and then 4 to 6 over the lifetime on average. So it's definitely a chronic disease. It's definitely one that needs to be treated, and probably one that you'll see a lot in your practice. Suicide. So suicide is the 10th leading cause of death overall, and the second leading cause of death for ages 10 to 14 and 25 to 34, and the third and almost second for ages 15 to 24. So the first leading cause of death is vehicle accidents, like car accidents. So it's interesting that the second leading cause of death for kids ages 10 to 14 is suicide, which it's pretty scary. Among adults, 15 to 6% report a lifetime history of suicidal ideation, and 5% have made a suicide attempt. So we're going to look at the difference in those numbers. It'll be really important as a clinician to understand the difference between a suicidal ideation and a suicidal attempt, and how to kind of figure out which one is occurring. 23 to 95% of people who die from suicide suffer from mood disorders at the time of their death. Again, a huge range, a huge number, 23 to 95%. So the research it definitely, it has a huge effect on it, but it's unclear as to what percentage of people really this is happening to. And then the major depressive disorder diagnosis is most strongly associated with suicidal ideation. But among those with high suicidal ideation, attempts are predicted by disorders related to anxiety, agitation, poor behavioral control, bipolar, anxiety, substance use disorders. So they all play a role in suicidal ideation, but by far major depressive disorder is the most strongly associated or strongly correlated with suicidal ideation. Sociodemographic risk factors for suicide, so gender. Women are more likely to attempt and report more ideation. So that's those thinking. That ideation is like, I'm thinking about killing myself. Men are more likely to actually succeed and to die from suicide. In terms of ethnicity, whites or Native Americans are more likely to have suicidal ideations. If you're over 60 years old, you're more likely to have suicidal ideations. If you're living alone, if you have social isolation, if you're unemployed and you have financial difficulties, which also plays into this social isolation piece, because I think, as you know, a lot of adults, our social outlets are at work. So if you're unemployed and you're living alone, then you're home a lot of the time. Recent adverse life events, so if something happens, something negative in your life happens, and then chronic illness. There's a lot of research around chronic illness and suicide. So some risks and protective factors for suicide. So risks include previous attempts. Have you tried to commit suicide in the past? Clinical depression, like we said, because major depressive disorder is strongly correlated with suicide, and schizophrenia. Impulsivity, so kind of not having control over yourself. Substance abuse, and we've seen, just in the media, we've seen a lot of people that overdose or commit suicide. It gets kind of muddy. The waters get kind of muddied around that. This feeling of overall hopelessness, like there is just nothing for me in the future, so why should I even go on? And then severe loss of interest. So the severe anhedonia, like I am so sad, I am so hopeless, and I don't find pleasure in anything. And then protective factors, family support. Children is a huge protective factor that they found for suicide, having children, having a great social support, and then a religious affiliation or participation in a religious group. So all of those talk about community, having a community around you, having support around you, not being isolated. Those are the protective factors for suicide. So stress and depression. Stress is really interesting, and obviously we all feel stressed. You guys might feel stress right at this moment listening to this PowerPoint. I hope that you don't. So what is stress? What is the definition of stress? Stress is a state of mental tension and worry caused by problems in your life and your work and etc. And something that causes strong feelings of worry or anxiety. So 80% of depressed cases are preceded by major life events. So in terms of major life events, you're looking at things like significant loss. So I lost a loved one, or I lost my pet, or I lost my job, or I lost my home, which obviously stresses you out and might lead you to feel depressed. And depressed patients are 2.5 times more likely to report stressors than controls. So those are non-depressed patients. And the moderators of stress on depression. So what affects it? Gender affects it. Again, it's more common in women than in men. High cognitive vulnerability, early adversity or loss of a parent, and then lack of a confiding relationship. So there's a couple of types of stress. There's acute versus chronic stress. So acute is like all of a sudden something happens and you are totally stressed out about it, but then you return back to normal. Your body goes back to normal. Chronic stress is when you're just at this level of stress all the time. I'm stressed about my job. I'm stressed about my marriage. I'm stressed about my kids. I'm stressed about my finances. And it never goes away. And chronic stress may be more closely related to depression. Interpersonal stress is stress in the relationships around us. Humiliation, entrapment, or targeted rejection themes. So I feel humiliated. I feel like everybody hates me, and it's stressing me out. Plus, that's a symptom of depression, right? This hopelessness, this feeling of rejection. So the two kind of work together. And then independent versus dependent stressors. So we have some pictures on the bottom there. So dependent stressors are events that a person, at least in part contributed to. For example, interpersonal events such as severe conflict or divorce. There's the broken heart down there. Or getting fired. There's our friend Donald Trump saying you're fired. Or failing out of school, getting an F out of school. So these are things that you're definitely stressed out about, but you had a little part in. Or there is independent stressors that are fateful events that a person has little or no influence over, such as the death of a spouse or a severe health problem, or as an extreme example, getting hit by lightning. Right? You don't have any say over that. Research shows that depression is predictive of later dependent events, but not later independent events. So I feel depressed, therefore I don't go to work, therefore I get fired. Or I am a kid and I have a major depressive episode and I just have no motivation, I feel empty all the time, I am not doing my work, and I fail. Versus, oh my God, my spouse just died, depression is predictive of later dependent events. So my spouse just died, it might lead to a major depressive episode. Treatment for depression, and we're going to go over this a lot in class. So here are some treatment modalities: behavior therapy, cognitive therapy, interpersonal therapy, problem-solving therapy, emotion-focused therapy, rational emotive behavioral therapy, and short-term psychodynamic therapy. So what I want you to do is I want you to pick one of these that seems interesting to you, or that you have some history around that you know about, or something that you want to learn a little bit more about, and just look it up and tell us what it is. And we're going to talk about them. We're going to talk about all these treatment modalities in class. So just pick one that sounds interesting. Look up some information on that and bring that to share with you. So I'll put in the reminders the 3 things that you have to do. I asked you 2 questions prior to this, and then I asked you to look up one of these treatment modalities. There is another reading that I just posted to Blackboard on SOAP notes, because we're going to learn how to write progress notes this week, and we'll go from there. Any questions, write them down, and we'll talk about all of them, and I hope that you guys have a good week.